Hello, everyone. Thank you for taking time out and being here today. I'm Sandro Esteves, and I'm delighted to participate in this virtual workshop for fertility nurses and midwives organized by Medea. Today, I will share with you essential knowledge on semen analysis. This slide includes my disclosures. I have no potential conflict of interest related to the contents of my presentation. Here is an outline of what I'll be covering today. I will discuss the importance of the semen analysis and how it should be performed according to the WHO manual. I will also provide you with an overview of advanced semen tests and what the WHO manual recommends. And lastly, I will explain how the results of semen analysis can help decision-making in the IVF unit. So let's get started. Since the 80s, the WHO manuals have provided us guidance on how to perform semen analysis. These manuals are revised periodically, incorporating new evidence and refining concepts that need more explanation. Each manual includes protocols and reference standards. And although these manuals are not kind of used for all clinics across the globe, they have been quite significantly used by IVF units, andrology laboratories, and this is the manuals that we use in our clinics for assessing the semen analysis, and I believe they are used in yours as well. In this recent article that I invite you to read, I critically assessed the evolution of the WHO manuals, focusing on the last two editions, and also the value of semen analysis in the management of couple infertility. I will discuss the most important aspects of this publication in the following slides. So the fifth edition of the WHO manual, published in 2010, is currently the manual used worldwide by most clinical and research andrology laboratories, as well as fertility centers. This manual has a section dedicated to basic semen analysis, and also a section dedicated to advanced testing, optional testings, for example, biochemical assays and computer-assisted semen analysis, and also a section dedicated to research semen tests like oxidative stress and sperm DNA damage. It has also sections dedicated to sperm preparation techniques and sperm cryopreservation, and a section about quality control and quality assurance. But perhaps the most remarkable change between the 2010 manual and its predecessors was the incorporation of clinical chemistry foundations to generate reference ranges for semen volume and basic semen parameters. Using data of recent fathers, the distribution's 50 percentile values of semen volume, sperm concentration, total sperm count, total motility, progressive motility, morphology, evaluated by the strict criteria, and vitality were chosen as the lower reference limits. This is what you see when you have reports on semen analysis. These reference ranges are presented for evaluating the patient profile and then comparing to the reference ranges. These 2010 reference limits were substantially different from those of former manuals, raising much debate. That reference limits in the manuals before 2010 relied on the clinical experience of researchers evaluating sperm parameters in fertile men with not specified time to pregnancy. This is not ideal because over or under referral for male infertility investigation or also IVF-ICSI treatment can happen when decisions are made based on imprecisely defined reference populations. But I feel it's essential for you to understand how the 2010 values were generated. So our reference range was obtained from a relatively well-defined population of recent fathers for the first time. Recent fathers were defined as men from couples who had achieved a natural pregnancy within 1 year from stopping contraception. Patients who were attending an infertility clinic or undergoing fertility assessment were excluded. So the semen analysis of the so-called recent fathers were carried out in laboratories applying rigorous analytical methods and enrolled in quality control programs. On this basis, it was assumed that this population best represented fertile men. However, criticisms were raised because data from only about 2,000 men from restricted geographic regions were used for generating the reference ranges. Despite that, the 2010 reference limits have been used extensively since the manual release for decision-making. Now, after 10 years since the last manual, the much anticipated 6th edition was released in 2021 with important updates. Several chapters were revised and new chapters were added, particularly concerning advanced sperm function tests. Protocols to perform tests that became obsolete were discontinued, like the sperm penetration assays. The new chapters mainly included information about the potential clinical utility of sperm function testing, like sperm DNA fragmentation and oxidative stress. The manual provides step-by-step protocols on how these tests should be performed. And unlike previous editions labeling advanced sperm function assessment as research tests, the new manual acknowledges that sperm DNA fragmentation and sperm aneuploidy tests, for example, may be clinically informative in certain situations by the laboratory choice or clinician's particular request. The sperm processing and cryopreservation chapters were improved as well, with more detailed protocols, and the section related to quality control and quality assurance was revised to facilitate understanding by non-statisticians. An essential feature of the 2021 manual was the incorporation of new semen analysis data from recent fathers, updating the reference distribution of semen parameters that had been published in the previous edition. In this 2021 edition, semen analysis data from 5 countries published since the release of the 2010 manual, and including about 1,800 recent fathers from Italy, Greece, Iran, Egypt, and China were added. These data were pooled with those used to generate the 2010 reference ranges. Collectively, the reference interval provided in the 2021 manual originates from a population nearly twice higher than the 2010 edition. Based on the new pooled data, the 50th percentile values for sperm volume concentration, motility, and morphology distributions differed slightly from those of the 2010 edition. But the similarities between the two manuals are good news. They indicate that the inclusion of more diverse populations did not change the reference ranges significantly, suggesting more generalizability. Still, densely populated geographic regions remain underrepresented, and we don't know if values will change when data from these regions are incorporated. What is essential to understand is that you need to exercise caution when using the WHO semen analysis reference values for decision-making. Always remember that these values only represent the distribution of semen parameters of a limited group of recent fathers from quite a few countries. We still don't know whether regional reference values would be more clinically relevant than values obtained by pooling the data from different populations. I will give you a brief overview now on how a semen analysis should be performed according to the WHO 2021 guidelines. Basic semen analysis has 4 critical pillars. First, pre-analytical aspects, including patient instructions on how to provide the specimen, ejaculatory abstinence that should be always between 2 to 7 days, and recording of any medication that could affect the results. Second, the microscopic examination of seminal fluid, mainly including pH and semen volume. This needs to be carried out by weighting the specimen because the volume assessment by pipetting underestimates the amount of fluid. Third, Microscopic examination, which includes assessment of sperm concentration, total sperm count, motility, vitality, and morphology. For count and motility, replicate assessments are recommended. Each replicate is a separate fresh wet preparation. And as sperm motility decreases with time after ejaculation, the examination should start within 30 minutes of ejaculation when liquefaction is complete. A standard temperature of 37 degrees for sperm motility assessment is also required. Morphology should be evaluated by the strict criteria, and vitality assessment is only necessary when total motility is less than 40%. Lastly, post-analytical aspects relating to calculations, reporting of results, quality control, and quality assurance is also kind of important for the semen analysis performed according to the WHO manual. Here you can see the main new recommendations and updated information provided by the 2021 manual concerning the basic semen analysis. Perhaps the most significant change regards sperm motility categorization, which was reverted to that of the 1999 WHO manual, in which sperm are classified as fast progressive, grade A, slow progressive, grade B, non-progressively, motile, grade C, and immoral, grade D. In the new manual, a section named Extended Examination was included, grouping the tests that may be used clinically in certain situations by choice of the laboratory or particular request from the clinician. Some tests, like sperm DNA fragmentation, were upgraded because they were considered only research tools in the previous edition. Others, like, for example, assessment of leukocytes in semen, were downgraded, as in the previous manual, leukocyte assessment were part of the basic semen examination. Extended examinations include many tests, but today I want to talk about sperm DNA fragmentation because I consider that this test highly informative in investigating the competence of the human sperm to fertilize the egg and promote healthy embryo development. The new manual includes protocols for the main sperm DNA fragmentation tests, the tunnel assay, sperm chromatin dispersion test, also known as the halo test, the comet assay, and the sperm chromatin structure assay. We recently reviewed the evidence and elaborated a clinical practice guideline concerning the situations where sperm DNA fragmentation testing may be indicated. The guideline development group included reproductive urologists like myself, scientists involved in the development of the tests, and reproductive endocrinologists. If you are interested to learn more about sperm DNA fragmentation, I invite you to check this open access paper published in journal named Andrology. In brief, for a reliable assessment of sperm DNA fragmentation, it is critical to use a validated test. The examination must be carried out in neat semen collected after ejaculatory abstinence of 2 to 5 days, but preferentially 2 to 3 days. Concerning ejaculation interval, it is critical to use a fixed ejaculatory abstinence length when the test is used to monitor the effects of any intervention to reduce sperm DNA fragmentation levels. If correctly performed, the 4 sperm DNA fragmentation tests provide valid information concerning the risk of male infertility and the probability of reproductive success, both for natural and assisted conception. Examples of situations in which these tests can be clinically informative for explanatory purpose or clinical decision-making, including varicocele, particularly in cases of palpable varicocele and borderline or normal basic semen analysis, in which there is doubt whether or not the varicocele should be fixed according to the recommendations of the most relevant urological guidelines. Second, in cases of unexplained couple infertility or idiopathic male infertility. Third, in cases of recurrent pregnancy loss. Fourth, before intrauterine insemination. Fifth, before IVF-ICSI, particularly when a paternal factor is suspected. Sixth, for fertility counseling mainly when risk factors for oxidative stress exist and before sperm banking. In these conditions, sperm DNA fragmentation testing can provide helpful information about the contribution of sperm chromatin to infertility and possibly guide the treatment plan. Sperm DNA fragmentation tests have also been included in other relevant clinical guidelines. For instance, the 2017 ASHRAE recurrent pregnancy loss guidelines provide a conditional recommendation for sperm DNA fragmentation testing during the investigation, based on a moderate association between pathological sperm DNA fragmentation levels and recurrent pregnancy loss. Indeed, current evidence indicates that sperm DNA fragmentation levels are markedly higher in the partners of women suffering from recurrent pregnancy loss than in controls. And more recently, the European Association of Urology Male Infertility Guidelines provided a strong recommendation for assessing sperm DNA fragmentation in couples with recurrent pregnancy loss from natural conception or failed ART, and for men with unexplained infertility. Also, last year, the joint ASRM-AUA male infertility guidelines included a recommendation for sperm DNA fragmentation testing in men from couples having recurrent pregnancy loss. The main advantage of performing sperm DNA fragmentation tests in these scenarios is that it allows initiating an andrological assessment for men who would not otherwise be routinely viewed by specialists. The andrological investigation provides the opportunity to identify and correct reversible causes associated with sperm DNA fragmentation, potentially increasing the chances of natural conception or potentially improving ART outcomes. We recently summarized the rationale and effects of the primary interventions in this review article published in Andrology, which I also invite you to check. It includes information on lifestyle modifications, antioxidant therapy, treatment of underlying conditions like a varicocele, genital infections, and chronic diseases, hormonal therapy, and also the use of testicular sperm in preference over ejaculated sperm for ICSI. Now I want to move to my last point, semen analysis results and decision-making in the ART unit, where I believe most of you work. The semen analysis is the most critical laboratory test to evaluate men's fertility aptitude. It provides information about spermatogenesis and accessory glands function that might help in diagnosis, counseling, and follow-up of male infertility treatment. The results of semen analysis also help in choosing sperm selection techniques for IUI, IVF, and ICSI, selecting the most optimal assisted conception modality, and certain decisions in the ART units, like the need for precautionary cryopreservation. But what is essential to understand is that semen analysis is a complex laboratory procedure that needs to be performed in an andrology laboratory equipped with well-trained technicians, internal and external quality control, validated systems and processes, and quality assurance. Reliability and accuracy are essential because semen analysis is frequently the gateway test on which basis costly and invasive treatments are prescribed. Clinicians should consider these aspects when choosing a laboratory to perform their patient's semen analysis. Concerning the usefulness of semen analysis results for the choice of sperm selection techniques, we need to acknowledge that there is no consensus. What is essential to know is that traditional sperm selection techniques are not ideal for selecting sperm fractions with optimal DNA integrity and functional characteristics. Swim up, for example, is limited to semen with high sperm count and good motility. The density gradient centrifugation, by contrast, allows recovery of higher sperm yield and is more suitable for oligozoospermic and poor sperm quality specimens. But centrifugation can increase sperm DNA fragmentation induced by reactive oxygen species. Advanced sperm selection techniques have now been introduced for potentially optimizing functional sperm recovery for use in IUI and IVF-ICSI. However, the best quality research does not show any essential differences in live birth rates when these techniques are compared with the density gradient centrifugation or SWIM-up. Currently, there is insufficient data to support the use of advanced sperm selection techniques routinely for sperm preparation. They're using specific groups of patients, such as those with elevated sperm DNA fragmentation, remains to be explored. In our clinic, we use different techniques according to the patient profile. In your clinic, you need to choose the best sperm selection technique that best suits your needs based on your own semen analysis experience, available resources, and also costs. Here's a snapshot of what we use in our clinic. We routinely combine the results of the basic semen analysis and sperm DNA fragmentation testing for decision-making. Density gradient centrifugation, SWIM-up, or microfluidics devices are typically used for selecting sperm for ART, mainly based on sperm concentration, total sperm count, and motility in our clinic. Sperm DNA fragmentation test results are also used for decision-making, and in selected cases of elevated sperm DNA fragmentation, our approach is to use testicular sperm for ICSI. The semen analysis results may also help in choosing the most suitable assisted conception treatment. Like the previous topic, there is highly variability among clinics in this area. And in this particular case, decisions should be based on combining semen analysis results with the couple's clinical characteristics. In general terms, IUI is considered for eligible couples when semen analysis show normal zoospermia or mild oligoasthenozoospermia. And some groups like ours also use sperm DNA fragmentation testing results for eligibility criteria. Conventional IVF is generally considered for couples with unexplained infertility, pure female infertility factors, or mild semen abnormalities. The indications for ICSI primarily include severe male infertility, but its use in non-male factor indications has increased steadily in recent years. Nowadays, ICSI as a method of fertilization represents about 70% of all ART cases performed worldwide, with some regional variations. The semen analysis results are also potentially beneficial to deciding on the need to cryobank sperm as a precautionary measure. This strategy can be of particular value for patients with sperm counts at the extreme lower limits, including patients with semen analysis showing fluctuations between azoospermia, severe oligozoospermia, and cryptozoospermia. These patients are usually under a lot of stress during the ART treatment and may have difficulties providing a specimen suitable for ICSI on the day of oocyte pickup. Patients with difficulties in providing a specimen for semen analysis may also benefit from cryobanking. It may avoid unpleasant situations on the day of oocyte pickup. And for low sperm quantities, our approach has been to use sperm vitrification, like the cell sleeper method illustrated in this slide. Lastly, severe morphological defects on a semen analysis, such as the lack of acrosome, short tails, or mid-piece abnormalities, could prompt the lab to apply oocyte activation after ICSI. This strategy has been shown to improve pregnancy rates potentially in couples whose male partners have these abnormalities detected on a semen analysis. But although the results of semen analysis might be helpful for better decision-making in the ART unit, what is essential to discuss is that, unfortunately, the male partner is often overlooked in the evaluation and treatment of infertility. A semen analysis is frequently the only test to assess a man's fertility potential. However, as reasoned in this comment I have written for The Lancet, a male infertility workup primarily based on a basic semen analysis does not provide men with an optimal fertility pathway for three main reasons. First, basic semen parameters do not reliably discriminate fertile from subfertile men. In fact, there's a substantial overlap between semen analysis results of these individuals. And in about 30% of men facing infertility, the routine semen parameters are within the reference ranges. Second, the results of a basic semen analysis have a low predictive value for natural fertilization and also ART success, unless the sperm parameters are at the lowest limits. And third, semen analysis, as routinely performed, does not include functional tests and therefore is unable to detect sperm DNA and epigenetic alterations that might affect embryo development and implantation and also offspring health. Additionally, female factors also adversely affect a couple's fertility potential. This is why a simultaneous assessment of both partners is required to determine the fertility potential of every couple, and the most recent clinical guidelines have stressed this essential knowledge. A well-conducted male infertility workup must include a detailed medical and reproductive history of the patient, physical examination, and at least 2 basic semen analyses as a first-line investigation. Second-line investigation, such as hormonal assessment, sperm functional tests, genetic analysis, and imaging studies might be necessary based on the clinical and semen analysis finding. I firmly believe that all men from a subfertile couple should be assessed by well-trained urologists or andrologists who have expertise in male reproduction, which is the routine practice in our clinics. A comprehensive male infertility evaluation has several advantages. It can help identify potentially correctable conditions, such as varicocele, genital tract infections, obstruction, endocrine disorders, inadequate lifestyle, and exposure to toxicants, just to cite a few. Second, it can identify conditions that cannot be treated, but are suitable for IVF-ICSI using the patient's own sperm. Third, it can also help in recognizing situations where donor insemination or adoption are the only alternatives. A complete male infertility evaluation might also identify health-threatening conditions or related coexistent diseases that require medical care. And lastly, it could reveal conditions that might affect patient or offspring health, mainly in patients using ART. We can cite, for example, advanced paternal age, inadequate lifestyle, use of potentially gonadotropic or teratogenic medication, and also genetic defects. And based on this evaluation, the affected couples can be counseled accordingly. That brings us to the end. In conclusion, global standardization is needed for development in andrology, and the WHO Semen Analysis Manual is a valuable instrument to move clinical practice and research in male reproductive health and andrology. Traditional semen analysis remains a very important component of male infertility evaluation, but still, an advanced sperm function assessment is needed to identify specific sperm defects, adding knowledge for fertility counseling, diagnosis, and treatment planning. However, medical and infertility conditions underlying an abnormal semen analysis or an abnormal sperm functional test will only be reviewed and potentially treated or alleviated through a complete male infertility workup. The good news is that male infertility has been increasingly recognized as a disease and a public health concern. Its prevention and management should be an integral part of an inclusive sexual and reproductive health agenda. But to ensure a bright future for male reproductive health and andrology, we need more investment in research, technical innovation, education, and training. I'm providing you with a list of key references, but feel free to contact me by email if you need further information. Thank you very much for being with me today.